Necrotizing fasciitis is a life-threatening infection of the soft tissue. It goes through the facial planes. The patient will have signs of disproportionate pain, bullae formation, crepitus, skin necrosis, discoloration, fever, and swelling and wooden heart feeling. A bedside test like dishwater abscess by a finger swipe technique is also diagnostic. Classification: number 1 is polymicrobial, number 2 is monomicrobial, that is basically group A streptococci or beta hemolytic streptococci. Type 3 is marine or gram-negative rods or endotoxins, and type 4 is candida, fungal infection. The lab investigations are important, and the lab's investigations can help you quantify with a Lernick score, that is laboratory risk indication for necrotizing fasciitis. A score of less than 6 is a low risk, 6 to 7 is intermediate, and more than 8 is a high risk. It consists of 6 important markers or units. Number 1 is CRP, number 2 is WBC count, number 3 is sodium, number 4 is creatinine, number 5 is hemoglobin, and number 6 is glucose. CRP of more than 15 gives you a score of 4. 15 milligram per deciliter gives you a score of 4, while less than 15 milligram per deciliter per liter milligram per liter gives you a score of 0. WBC count, if less than 20 is score 0, 20 to 30 is scored at 1, and more than 30 is scored at 2. Hemoglobin, if more than 135 scores 0, but if less than 11 scores 2. Sodium, if less than 135 scores 2, if more than 135 scores 0. Creatinine, if it is more than 141, it gives you a score of 2. And glucose, if more than 10, gives you a score of 1. So it is CRP, WBC count, hemoglobin, sodium, creatinine, and glucose. It has a positive predictive value of 92% if more than 6. Complication of necrotizing fasciitis is full-blown septic shock and ARDS and death. Surgical excision is important. Orthoplastic intervention is required. Operative findings is liquefied fat tissue, easy to dissect subcutaneous tissues with finger swipe, going through dermofacial layers. A dishwasher abscess is found. Muscles and fascia necrosis happen, and there is lack of bleeding, and there is venous thrombosis. MDT approach is indicated with the help of microbiologist, ICU care, fluid resuscitation, and nutritional support. A WAC is difficult to apply for large surface area and can cause significant blood loss. IV antibiotics is indicated, and repeat debridement within after 24 hours. If there is streptococcal or Clostridia infection, penicillin G is indicated. If polymicrobial, then imipenem or atrapenam is indicated. Otherwise, if MRSA is indicated, vancomycin or daptomycin can be started. A similar infection is gas gangrene. A gas gangrene is Clostridium perfringens infections, or protease infections, or Pseudomonas infections can also cause gas gangrene. produce exotoxins which cause necrosis of the fat and muscles. Present with skin necrosis, discoloration in the perineum and the thigh. It has longer incubation period of more than 3 days. X-ray shows gas in the soft tissue. Blood culture rarely grows clostridia. Treatment is excessive surgical debridement and antibiotics.